So welcome everybody. So we are going to have our ACNS Haneda MVD webinar today, and we have three speakers for today. The first speaker is Professor Fuminari Komatsu, second speaker is Professor Li Shitting, and third speaker is Professor Yuan Li. We have chairs Professor Yoko Kato and Professor John Chung with us, and discussant as Dr. Dilshad Kojimoto. So may I please hand this podium over to our Honorable President of Yoko Kato for her opening remarks.
Okay, thank you very much we are very honored to receive the three speakers. So I think shortage of time, maybe we can start. Maybe Chair, Dr. Jun, can you chair the session, please?
Please unmute your mic, Professor Jun. Can you press unmute, Dr. Jun? Your mic is muted.
I'm sorry, I just help Dr. Li to finish the process. He can log in. So maybe we can start firstly. Sorry for that.
So can you introduce Professor Komatsu, please?
Your mic is still muted, Prof. Can you please unmute your mic?
I'm really sorry. Dr. Li Professor Li got some problem with the login. So we can start firstly. So the first speaker, I'm sorry, I didn't hear you. So you want me to moderate to introduce the first speaker or
yes,
something?
Prof. Yes.
Yeah, the first speaker from Japan. We welcome Professor Fuminari to make the first presentation. Please, Dr. Fuminari.
Thank you for the introduction, Professor John Jun. It's my great pleasure to meet you online. We met before in China and Japan, both. So, can I share my screen first? Can you see my screen? Okay, thank you.
Can you make it full screen?
Okay. So let's start. So today's my topic is the endoscopic microvascular decompression for trigeminal neuralgia and the hemifacial spasm, a new trend of endoscopic keyhole surgery. So now I'm working in Nagoya, Fujita Health University Bantane Hospital. These are our colleagues, and I studied endoscopic anatomy more than 10 years ago in Vienna, Austria. I studied the basic principle of endoscopy there. And then also, I have some clinical experience in India. I have a lot of clinical cases there. So, I want to return to the topic. So today, I'd like to talk about endoscopic microvascular decompression. And successful microvascular decompression requires two elements. So precise identification of neurovascular conflict and appropriate decompression. And the endoscope provides the panoramic views even in the deep surgical field. So, and also the transposition technique is a desirable method for long-term outcomes. So I'd like to introduce our pure endoscopic microvascular decompression. So the patient is placed in the park bench position. Skin incision or less than 4 centimeter is made, and then approximately 1.5 centimeter retrosigmoid keyhole is created, and the endoscope is connected to the pneumatic endoscope holder, and the single shaft instrument used, and BAEP, hearing monitoring, is continuously monitored. This is a picture during the operation. We use the 4K ICG endoscope system. This equipment, we use the Mitaka endoscope holder and the sectors, all and the scissors, all the single shaft instrument, and alligator forceps are also used. As for decompression, the two types of the decompression is known. The first one is the interposition. The prosthesis is inserted between the cranial nerve and the offending artery. And another decompression method is transposition. The offending artery is separated away from the cranial nerve. So we basically do the transposition even under the endoscopy. And also we use the transposition with fibrin glue only. And the offending artery is fixed with fibrin glue only. It's attached on the dura or tentorium. This is very easy and suitable for endoscopy. I show some illustrative cases. The first case is the trigeminal neuralgia left side. Offending artery is SCA in the 3D image. The video is shown, skin incision, and then this is the keyhole, approximately 1.5 centimeter, and 0-degree endoscope is inserted. Now we can see the trigeminal nerve. It's compressed by the SCA, same as the preoperative image. ICG is given. So the arachnoid around the trigeminal nerve is bluntly dissected in this case, and the SCA is easily mobilized. And this offending artery is separated from the trigeminal nerve and attached on the tentorium, and it's fixed with fibrin glue. Now it's confirmed. And also the trigeminal nerve is separated from the petrosal vein. This is the final view of this case. So the pre and post decompression is shown. The next case is also the trigeminal neuralgia. Sometimes the petrosal vein restrict the visualization of the trigeminal nerve, but the endoscope will visualize the structure behind the obstacle. Similar to previous case, the trigeminal nerve was compressed by the SCA. So SCA was again mobilized and attached on the dura. After the decompression, we can see the important anatomical structure even behind the developed petrosal vein. And another case, this is the trigeminal neuralgia, offending artery is trigeminal-cerebral artery. So video is shown. And now we can see the trigeminal nerve. And also the trigeminal-cerebral artery, TCA, is penetrating the trigeminal nerve near the Meckel cave. ICG is given. And then all the vessel attaching on the trigeminal nerve is separated. Initially, the SCA is separated and attached on the dura with fibrin glue. And the next, now we can see the trigeminal cerebral artery, proximal side. It's attaching on the root entry zone. But because of the perforators, a complete transposition was impossible. That's why the Teflon was also inserted. Finally, the distal part of the TCA is also mobilized and attached on the dura, tentorium. So this is the final view. All the arteries separated from the trigeminal nerve. And in our series, TCA trigeminal cerebral artery is observed approximately 3.4%, where excellent decompression was performed in this case. So next, hemifacial spasm. This is a hemifacial spasm, right side. The ICA is offending artery in the image. So video is shown. The incision is almost same as the trigeminal nerve. After making incision, then the keyhole is created, and then endoscope is inserted. This is a 0-degree endoscopic view between 8 and nerve, and then the 30-degree endoscope inserted. Now we can see the offending artery ICA is running on the facial nerve. This ICA is separated from the facial nerve, and also the attached on the dura, and again fixed with fibrin glue. Now we can see the indentation clearly. You see the indentation on the facial nerve, and offending artery is attached on the dura. All perforators are completely preserved. This is pre and post surgical views. Next case is the hemifacial spasm. This case, the ICA-PICA common trunk arising from the vertebral artery, and also the ICA branch and the PICA branch from the APC, all offending arteries. So video is again shown, incision and keyhole, and then the scope inserted, 0-degree endoscope between 8 and 9, and then 30-degree endoscope inserted. We can see the icon, the pica branches, as it is given. We cannot see the facial nerve at this moment, but after mobilizing the ICA branch, we identify the facial nerve. So that's why the ICA is mobilized and attached on the dura little by little. Fibrin glue is very useful. Now we can see the bifurcation of the ICA-PICA common trunk. It was also attached on the dura. And then finally, the PICA branch is fixed on the dura. So now we can see the indentation on the facial nerve. Again, all the perforators are clearly visualized. The pre and post surgical views are shown. Next case is a hemifacial spasm. Preoperative image shows that the vertebral artery is offending artery. This is skin incision, keyhole, and then again between 8 and 9, 30-degree endoscope inserted. We can see the vertebral artery very clearly. So in the same manner, the vertebral artery is lifted and fixed on the dura with fibrin glue. Plenty of the fibrin glue is applied and fixed on the dura. So now we can see the facial nerve. Indentation on the facial nerve is clearly visualized. And these are pre and post surgical views. I think this is the last case, the hemifacial spasm left side. Again, the vertebral artery is offending artery. But during the operation, we identify the variant artery.
然后是如果我们要共享呢，再等会儿。
subrachate fossa.
先
So this restrict again the restrict approach to the CP angle. So that's why the dura is partially separated. And then the scope inserted. Again, 30-degree endoscope shows the vertebral artery is compressing the facial nerve. So between the small space, the vertebral artery is lifted. Pica from vertebral artery is also observed. So this offending vessels are fixed with fibrin glue. So offending arteries are completely lifted from the facial nerve. Even such a variant case, all vessels are completely preserved. ICs finally showed the penetration of the oral arteries. This kind of the ICA adhesion cases were or approximately 3.3% in our cities. So I showed the surgical result. Last 4 years, we experienced more than 500 pure endoscopic microvascular decompression cases. So in last case, the 200 cases were operated, and trigeminal neuralgia, pure classical trigeminal neuralgia remission was more than 90%, 94.5% was achieved. As for hemifacial spasm, 90.7% spasm were almost recovered. And this is the permanent complication. The hearing impairment was only 0.5%. CSF leakage was not observed, and wound infection requiring debridement, it was 0.5%. So in discussion, for the microvascular decompression, endoscopy or microscopy, that's a big I think the discussion point. I strongly believe the endoscopy is better than microscopy, but literature says that some literatures say the endoscopy is better than microscope, but others also say that between the endoscope and the microscope, there's no significant difference in terms of the clinical outcomes. But from other viewpoint, Dr. Li from United States report that surgical result is same in the endoscopy and between the endoscopy and the microscopy, but less postoperative headache is observed, meaning that less invasive surgery can be achieved in the endoscopic groups. So I think it's still controversial to conclude the surgical result between two groups, but we can say the endoscopy has significant difference regarding minimally invasiveness. So these are conclusions. So thank you for your attention. And finally, I'd like to give some small announcement. We will open the Fujisawa Health University Haneda Clinic. We accept the international patient soon there. So thank you very much.
Thank you to Professor Fuminari. So such a wonderful presentation. What impressed us is you use the microscopy or endoscopy. So I think just not a question. Endoscopy or microscopy or even exoscopy. That's out of question. I mean, no matter any scope is okay. The most important thing, not the size of the craniotomy. The most important thing is the angle of your approach. So I think there are some disadvantage because actually for endoscopy, you put your operated eyes to very closer to the target, to the nerve. But if you put your eye too close to the nerve, for example, if you across the fifth, that means the eighth and the seventh is behind your eye. You can't see the eighth and the seventh. So that got some problem to damages as the acoustic nerve or facial nerve, or even some superficial vessels, pedural vessels. But I'm not have experience with endoscopy. So that's what I understanding, I think. Even I would say is in this way. For a new neurosurgery, you want to do the MVD surgery, I think endoscopy is has a good future. because you can see it much clearly. But for one generation, we get used to the microscopy. I say, okay, we can continue to do the microscopy. So I remember about 10 years ago, when I submitted a paper about the MVD to the journal, and the reviewer, they asked me, he questioned me. He said, one of your picture is supposed to be taken in the endoscopy. Actually, this picture was taken just in the microscopy. That means if you have a good understanding for the anatomy, you can even get the dissection into very deeply, just like endoscopy. You can do the same view. So that's my understanding of the endoscopy and in MVD surgery. So any comments and questions, please? The other. Did anyone got any questions and comment?
We have Dr. Dilshod as the discussant today. Dr. Dilshod.
Thank you, Professor Komatsu, for your outstanding lecture. You have demonstrated precious endoscopic techniques of microfield decompression. After seeing your presentation, now I want to do this with my patient, and I have some question for you. Based on your experience, what are the anatomical or procedural boundaries of using microscope in MVD or endoscope? Do you find limitation in visualization some arteries by using endoscope? And can we, before operation, decide in case of MVD, can we use endoscopic approach or microscopic approach, or in any cases we can use fully endoscopic approach?
Oh, thank you. Thank you for your question. Basically, we can manage all the authentic vessel, SCA, ICA, PICA, even the basilar and the vertebral artery. So I think the offending artery is not problem. But for example, in cases of the recurrence case, the adhesion is very problematic for the endoscopy because the very precise manipulation is sometimes difficult. So in such case, I think sometimes microscope is used for the recurrent case, but not all cases. Is that answer for your question? Right?
Thank you. And one question about hemifacial spasm. In some cases, we have delayed response for MVD. And in your experience, what is the main mechanism behind this delayed recovery of patient after hemifacial spasm?
Yeah, thank you very much. That's, I think, the general problem for all method. Even the endoscopy, it cannot accelerate. I mean, we cannot avoid the delayed cure. It's often happen even under the endoscopy. So probably the small injury of the cells in the facial nerve. It's happened before the already. Before the operation, it's already the small cells are broken, so that's why it happened. So I think so.
And are there any intraoperative markers or neurophysiological markers that help predict delayed response?
I don't think so. At least endoscopy cannot distinguish delayed cure or normal cure. I think so. Thank you. But it's very interesting.
Thank you, Professor, for your contribution to development of endoscopic MVD and Kehole approach. It's great. Thank you again.
Good. Now I got a question. So for your case, do you with the monitor, I mean the AMR monitor during the surgery for hemifacial spasm?
Thank you. Thank you very much. The monitoring is also important. We do the hearing monitoring during the operation, but we don't do the AMR or other monitoring for the facial nerve. We much rely on the visualization of the decompression by endoscopy rather than monitoring. Sometimes AMR is not reliable, especially in case of the delayed cure or something. So that's why we
So
don't
I
use it.
noticed your topic about the transposition technique. So I agree with you. Transposition is better than interposition. So that's why I use the glue. But I don't like the glue. I prefer to push the artery, the offending artery. I think push is easy. With glue means something like you pull the artery. So I would to beginning the anatomy, beginning disectomy from very low position. That means the caudal nerve to put the parent vessel. That means not the offending vessel. The small vessel is offending vessel. The bigger one, for example, the vertebral artery, that's the parent artery. So for hemifacial case, I would push the proximally, push the parent artery laterally, proximally. And when you put some Teflon, not Teflon, I mean the Jefflon, put between the parent vessels and the brainstem and push that means push the artery away. So when you reach the facial nerve, so actually the offending artery, the small one, already move away from the offending artery, the confident artery. So that's what I suggest. I would that way will be easy, and the push is easy. And when you pull it, that means push means you take it as it comes. That will be easy. It's not likely to be rebalanced. So that's my suggestion. Yeah.
Oh, okay. Oh, thank you.
Thank you. So to save time, let's move to the next speaker. The next is from Xinhua Hospital, Prof.Li. His topic is MVD treatment for Acromot nerves.
Dr. Jian.
I'm sorry.
So two more questions from the audience.
Do you want to ask a question?
No.
No, one is Dr. Raj.
Yeah.
Okay. We move to the other doctors. Yeah, please.
A very good evening. I'm Dr. Rajkumar. I'm from India, southern part of India, Bangalore. I'm currently doing my fellowship in Fujita Health University, Bantane. Every day I'm observing surgeries being done by Dr. Komatsu. So I had my experience with microscopic MVD. Endoscopic MVD I'm seeing firsthand now in Fujita Health University. So my opinion is compared to microscope, with endoscope, we can approach get same results with smaller incision, smaller craniotomy, and especially cerebellar retraction. Even though the posterior fossa volume is very less, cerebellar retraction is very, very less compared to microscope. And we can clearly evacuate all the CSF and make it more roomy with endoscope also. And the vision and view is very excellent with endoscope. We can see the medial aspect, root entry zone very clearly, especially when the offending artery is very medial and compressing at the root entry zone, which sometimes if we are operating under microscope, we may have to retract more and cause more tissue collateral damage. And especially perforator preservation, I'm observing very much clearly with endoscope. And along with that, if we are using indocyanine green dye, we can clearly separate arteries from the veins, and so that we can clearly decompress the nerve and approach good results. This is my comment. There are no questions, and I am very happy that I have the opportunity to observe Dr. Komatsu operating directly in the OR. And thank you so much for the opportunity, Dr. Yoko Kato and Dr. Komatsu, for giving me this opportunity. So my personal opinion is endoscopic MVD will be the future, and microscope may come down, especially with so many good results. Thank you.
Thank you.
Thank you.
Thank you, sir.
Okay, now let's welcome Professor Li Shiting, please.
No, Dr. Biswas.
Thank you, Sensei. for the opportunity. Constantly, it's always great to hear from you. I have two practical questions for you. Sir, whenever we try to concentrate in dissecting offending artery from the trigeminal nerve, we see that the facial nerve is in tension in the arachnoid band. If we don't dissect, we cannot reach up to the root entry zone of the trigeminal nerve. But postoperatively, patient presents with a bit of facial weakness. So what is the tips regarding this practical problem? It's number one. And number two is sometimes the stretching over the Dandy's vein in two cases caused quite a lot of bleeding. And I have used your technique to compress the Dandy's vein on both sides with fibrillar, and it stops. So I want to have a tips from you how to avoid a venous bleed in endoscopic approach.
Thank you very much. I cannot catch the first question. The arachnoid dissection. What problem happen by the arachnoid dissection?
Sir, when dissecting the offending artery from the trigeminal nerve, I see that the arachnoid band, I mean the facial nerve is in tension with the arachnoid band. So I have to dissect the facial nerve as well from the arachnoid band. Otherwise, I could not get to the root entry zone of the trigeminal nerve. But I see the patient develops facial weakness.
Facial weakness.
Yeah, facial weakness. But postoperatively, after a couple of weeks, it improves. So in two cases, it has happened.
I'm not sure, but you might damage something, the directly facial nerve or small perforate. I'm not sure, but
how to solve this problem? But there was no injury, just separation with the arachnoid band for the facial nerve. But possibly patient present with mild facial weakness, but it improved a couple of weeks later. But initial period, it was quite embarrassing as a surgeon.
But sometimes it happens very less frequently. But you always happen that, or
no, it's just in two cases.
in that case, I think it's not your fault. Maybe the
okay.
Another.
And another one is how to avoid venous bleed.
Venous bleed, I think just avoid the retraction. That's most important.
Okay.
As much as possible, I don't retract the cerebellum. So that's the only way.
That's okay. Okay, thank you, Sensei. It's always good to hear from you.
Thank you.
Okay, Dr. Jun, you can proceed.
I'm sorry, I didn't get the schedule, so I get some mistakes. So now this is the turn to the Dr. Li. Please, Dr. Li.
Hello, everyone. Could you see my PPT?
Yeah, we saw it.
Okay, it is my great pleasure to attend this meeting. The title of my report is MVD treatment for oculomotor nerve and abducens nerve paralysis. As you know, MVD is an effective method to treat a variety of the cranial nerve disease, such as trigeminal neuralgia, hemifacial spasm, and glossopharyngeal neuralgia, and so on. But there is a lack of effective treatment for primary oculomotor nerve paralysis and abducens nerve paralysis. Today, I will show some cases treated in Xinhua Hospital. Here, this is the first case is a male patient, 44 years old. He suffers from the right eyelid ptosis with diplopia for more than 1 year, and the cause is unknown. And he used various treatments are ineffective. So for these cases, we mix MR scan. From the MR scan, we can see the hyperplasia of the right temporal ancillary gyrus was obvious. And there was obvious vascular compression in the sister segment of the right oculomotor nerve. So for these cases, we first use the IMD surgery. So we use the terminal frontal temporal craniotomy with the lateral cerebrofacial approach. And we try to move the partial resection, the temporal ancillary gyrus, and with the MED procedure. So this is during the operation, we could find the ICA here, and this is temporal ancillary gyrus here, and we can find the ocular nerve was comprised by the gyrus here. So we remove the gyrus, and after this procedure, we can find this is the degeneration point, and this is the point of the compress. So we can see some change here. So, and then we use a sharp dissection around the ocular nerve, and to find the PC and IC compress the ocular nerve in the RZ region. So after this, we put some Teflon around the ocular nerve, and just like this. So you see, in the end of the surgery, you could find the frontal lobe, temporal lobe, and the lateral facial blood vessel was protected. And this is the final procedure. One week after surgery, you can see the tape term of the patient of the oculomotor paralysis was significantly improved. And this patient felt very well. And the diplopia improved significantly. So you can see the symptom disappeared and the patient very, very well. Now this is another patient. This is a male patient, 44 years old. She suffered the left oculomotor paralysis for 1 month. And the left eyelid ptosis with the diplopia is very obvious. So the same we use the MR scan, we can see there was obvious vascular compression in the cisner segment of the left oculomotor nerve, just here, here. So with the three-dimensional reconstruction, we can find the left ocular nerve was comprised by the PCA. So for these cases, we use the MED surgery. You can see during the operation, you can see the imaging result was consistent with what we seen during the surgery. Now here's the ICA, here's the ocular nerve, and you can see here is the PCA was comprised. So for these cases, we first with a sharp dissection around the ocular nerve. After this, we could find the vessel compressed in the IZ region. So we first sharp dissection the adhesion around the nerve. And after this, we use some sponge. We put some sponge between the nerve and the vessel and to enlarge the space. And this is very useful use this technique, we can enlarge the space. And after this, we put the pipe. This is very easy. So we piece by piece. This other is a PCA. We also put the Teflon sponge between the PC and the ocular nerve. we check along the optic nerve and we shot with the sharp dissection. Just cut all the adhesion around the nerve. So after this, it's easy to move the nerve. So this is the end. You can see the temporal lobe and the frontal lobe under the vessel in the little facial was intact. So you can see 6 months after surgery, you can see the symptom of the patient. We can see the symptom very well, and the diplopia improved significantly. You can see the function of the eye is normal.
Meanwhile, to save time, please allow me to make a short comment. So actually, for cranial disorders, we can divide it to two groups, two classification. One is, we said, like a hemifacial spasm or trigeminal neuralgia. Actually, they are a hyperexcitability disorder with a hyperfunctional. And the other group is lower functional, or say hypofunctional disorders. For example, the Acromot paralysis. The surgery is similar. We just decompression. And the most important thing, I think, is to sharply open the arachnoid, to cut the arachnoid before you retract the cerebellum. So that's very important, to cut sharply the arachnoid. Then you will have achieve a very good visual field. So that's very important. So how about the cable connect?
No, he hasn't been connected yet. If may I ask you one question, Prof. Jun?
Yeah, the other thing, I think, did you find the Professor Li put some gel film instead of Teflon between the nerve and the vessel? So the Teflon is more harder. It will likely to damage the nerve. The nerve is very soft. So if you use the gel film, that will be bad. Gel film is very soft. You can protect the damage from the nerve. So actually, the most important thing, I think, we have to find the leverage point of the offending artery. So actually, we didn't put the Teflon between the nerve and the artery. We just pull the artery away, then put some Teflon the other side. That means the leverage point of the offending artery, not put the conflict side. So that will be bad. So any other comment, please. We have some time to talk about.
Yes, sure. I would like to ask you one question, Prof. Like when you have asymptomatic neurovascular conflict, that is usually seen in an MRI of patients like in as high as 18 to 30%. Okay, so what is the reason that they do not have a trigeminal neuralgia?
Sorry, I didn't. Can you say that again?
In patients, there are several instances in the literature which are reported around 18 to 30% of neurovascular conflicts without trigeminal neuralgia. These patients sometimes do not have trigeminal neuralgia, even if there is a conflict. Why does it happen?
So you mean not every hemifacial spasm patient is caused by the offending artery? There's no offending artery. Is that your question?
No, there is a conflict between the vessel and the trigeminal nerve in asymptomatic patients. Why?
Without a symptom. If you found
Yes.
the trigeminal compressed by the artery, but
Yes.
there's no symptom, that's
That-
normal. So the mechanism is the nerve is damaged by the artery at the same a certain degree. That means exactly impact against the nerve that will trigger a spasm or an episode of pain. So that needs the exact pressure. So if the artery the conflict the nerve but not reach the degree, so there's no symptom. So that's my understanding. So exactly pressure, that's very important.
More than to it, we have there is a like the incidence of trigeminal neuralgia is very high compared to hemifacial spasm and the glossopharyngeal neuralgia. The reason being thereof is that the length of the root entry zone is the maximum in the trigeminal nerve, followed by the facial nerve, followed by the glossopharyngeal nerve. So when there is a conflict there, only those patients may develop symptoms. But in cases of where Professor Li Shiting showed, the compression on the oculomotor nerve was away from the root entry zone of the brainstem. So I am really surprised that they have this oculomotor nerve palsy.
Yes, it depends. There's a very diversity, so something we don't know.
Yes.
So I think we can move. Is there the other speaker, the third speaker?
Yes, Dr. Yuan Li. Dr. Yuan?
Yeah, we can move to Dr. Yuan Liu first. So please, Dr. Liu Yuan from Xuanwu Hospital in Beijing, please.
Can you see?
Yeah,
yes.
we can see
the PPT?
Yeah.
Good evening, Professor Kato, Zhongjun 教授, Ming Chu 教授, Fuminari, Professor Li Shiting 教授, Dishold, and other professors, Professor Lu. I'm Liu Yuan from Department of Neurosurgery of Xuanwu Hospital, Inner Mongolia. The hospital also called Chifeng Municipal Hospital. I have engaged in MVD from 2024, near 2 years. And have performed about 6 spasm during the surgery. I'll try to scope to to complete the surgery. Today, I will show some experiences of the MVD surgery. First, we should see the hemifacial epidemiological characteristics. First, sexual characteristics. Women's are near 2 times more likely hemifacial than men, typically presenting around age 45 to 50. And anatomical characteristics in or Asian, the convex shaped posterior cranial fossa with a favorable prognosis, flat shape. The figure B, flat shape posterior cranial fossa, is associated with poor outcomes. And number 3, genetic factors for example, MPD and APO and demyelinating lesions. And another is overexpression of sodium channel gene SCN10A may contribute to the abnormal muscle responses. And diagnostic of criteria for the HFS hemifacial spasm, most of the patients diagnosed can by clinical signs and symptoms difficult to diagnose. We use AMR to differentiate. Optomotor physiological monitoring for BAEP for auditory and LSR EMG for facial nerve. And this our operating room and the patient positioning, typically lateral decubitous position affected side up, head fixed by midfield or Dorer clamp, flexed and rotate to the exposed retrosigmoid, skin incision, and we often use a CT scan to locate the retrosigmoid. And use the direct gastric growth vertex at the top of. We often make a two hole to move the bone flap. Make two hole. The keyhole we often located on above the apex of their gastric growth vertex. About 1 centimeters, and another hole is vertex to the pecs below 2 centimeters, maybe. Inside the dural matter and take up the dural. One we need to visualization of the choroid plaques. Key points is first explore the exposure of chronic plexus at cerebellar puncti and preserve perforating veins whenever possible. Dynamic subsuction. Number 2, dissection along cerebellar surface to isolate chronic plaques towards the cranial nerve 9. Subflocular approach is most used. Key step is general separation. This is the video. Inside the dural matter and take up the dural. Application of anatomical structures. First, we need to identify the cranial nerve 7, 8 complex facial and vestibular ocular nerves. Carefully identify surrounding vascular most commonly the ICA, PICA, and VA and branches or veins. Focus on the nerve root exit zone from the brainstem, the most common site of vascular compression. Optimizing microscope angling minimize the retraction on the normal tissue. We can see the offending artery around in the microscope, and we adjust the microscope to make it more clear to see the offending vessels. and systematic exploration of offending vessels. We often use 3 steps to make sure to find the offending routes. First, a root entry zone of the number 2 is pontomedular sulcus, group between pons and medular common compression zone. Number 3, we use vessels accompanying by the perforating cranial nerve of 7. Offending vessel transversing through the facial nerve. This is very it's very hard to say. The offending vessel through the facial nerve bundle require meticulous micro dissection techniques. Let's say it, we protect the veins, and we say the offending vessels through the facial nerve bundle. That we use a micro dissector to dissect the offending vessels. And then we use a Teflon, insert the vessel and between vessel and the nerves. We use a few Teflon insert the facial nerve bundle around the offending vasculars. Decompression maneuver use a micro dissector or sucture tip to gently mobilize the offending vessel away from the nerve. Number 2 is place vessel and the brainstem nerve or around the vessels, creating the permanent cushion to animate pulsate side compression. Ensure the Teflon is securely positioned at new compression. Consider coagulating and dividing compressed vein if present. Next, I will show a case that with our intraoperative neural monitoring. First, we separate left vertebral artery from a facial nerve, and the second step is isolate the basilar artery within the medular sulcus using Teflon pouches. Number 3, separate artery from the accompany the 7 nerves. Fourth step is separate the petrol vein, and we confirm the LSR status when the intraoperative neurologist. Stable LSR waves from forms were elicited following cranioectomy. And when we the persistent LSR waveforms were documented following vertebral artery decompression. We also can see the stable LSR waveforms, and the persistent LSR waveforms were documented despite adequate insulation of the basilar artery within the medullary sulcus. We also can see the LSR. A significant reduction in LSR amplitude was documented following ICA decompression. And then we homeostasis and irrigation. Metulars inspect and surgical field for any active bleeding. Thoroughly irrigate the field with warm saline to remove the clot and debris. Closure that's through 3 times, and we use the burr hole, peak burr hole covers and connections minimize and to minimize artifacts on post-operative MRI scans, endoscopic assistant facial nerve MVD surgery. We use some structures, and when we say the offending vessel, we use the endoscopic to see the offending vessels and facial nerve and the relationship between offending vessels and facial nerve, and then we pull the Teflon between the nerve and vessels. And we also use the X-scope assistant MVD for facial nerve. This is a microscope field. This is X-scope field. Summary, no matter use microscope, endoscope, or X-scope, we felt that angles replace the and increase precision, replace guesswork. We need ensure that the precision by using intraoperative neural monitoring. This reference is. Thank you for your attention. Thank you.
Thank you, Professor Yu. It's a very interesting presentation. I realized that you mentioned you put the Teflon between the nerve and the offending artery, and just
Yes.
put the Teflon like a cousin. So you mean what's the role the Teflon play in MVD? So you mentioned that the role is to isolate the artery from the nerve. Is that right?
I think
because you mentioned that you should put it in between the nerve and the artery, but I don't think that's a very good idea. So the Teflon play is to just to keep the artery rebound. So I would suggest that you put the Teflon beyond the conflict site to find the leverage point. So that means that this is leverage point. This is our vessel. Here is leverage point. If we put this point away, it won't rebound. So that's the ideal, the best purpose we have to looking forward. So is there any questions and comment?
So what about your result? If the result is okay, I think it's okay. Yes.
The result is okay.
Okay, then it's all right.
Okay.
Professor, I have a question.
Kazu.
I have a question.
Hi. Yes, please go ahead. Dr. Wei?
Hello,
Please.
hello, Professor Yuan, Liu Yuan, Zhongjun, Professor. I'm a neuroscientist. I'm a fellow about now studying in Nagoya Bantai Hospital and study from Professor Yokokato and Komatsu. So my question is, do you perform interposition? Just perform the interposition? Do you perform transposition during the MVD? Because I think I have studied from Professor Komatsu. We usually perform the transposition during the operation, because we found transposition may be very better than interposition. So I want to ask, do you perform transposition during your operation? Thank you.
Oh, thank you. I just say some papers say that problem, say that question, and the answer is just like Kato's conclusion. These two different kind of technique is both useful in this kind of disease. I have heard that the VA, for example, the VA VA as a offending vessel, it's maybe it's more dangerous to transportation than insert the Teflon. This technique is more more safe. I think my consideration is that for some old people, there have some the problems in this vessel. If we move the vessel, maybe some thrombus to the brain, so it may cause the poor prognosis. So it's just my experience and my consideration. Thank you.
Okay. I'm making research about under the help of Professor Komatsu. I find if the remaining subarachnoid space about more than 5 millimeters, the transposition may be performed very easy. So during the 1 month, I have studied about 30 cases about MVD performed by Professor Komatsu. He always performed transposition very very easy. So but my research is about how to choose interposition or transposition before the operation or during the operation. So there's many things we can decide before operation. For example, the angle of the offending vessel, the remaining subarachnoid space, and one important thing during the operation to decide how to choose method is about the mobility of the vessels. Professor Komatsu just use endoscope. So during the operation, we can identify the offending vessel very clearly. So maybe transposition and interposition be choose very easier. So I think it's a very good habit. Maybe I think it shall be used more and more in the future. Thank you. Thank you.
Yes.
Yeah,
Thank
yeah.
you. Thank you.
Thank you. Thank you.
So in my opinion, we have to do transposition, and the interposition is your last choice. So that's your last choice. So no, you have to do the transposition. And I think the most common cause of recurrence is by the Teflon. The granuloma of Teflon is the new conflict, just like the same. Okay, all right. All right.
Thank you.
To save
Thank
time,
you.
we found Dr. Professor Li is ready now. Let's ask him to finish
Thank
the
you. Thank you.
topic. Please.
In the interest of time, can
Thank
we
you,
ask
thank
Prof.Li to make his summary?
Yeah, upon the Professor Li is ready.
Yeah, 又不行了，可以，
Can
行吗？
request Professor
行吗？
Li for a summary?
Yeah，有吗？
有，你讲。
啊，有吗？
有，你
我怎么
讲。
没看见？现在看得见吗？
看得见。
哎，
看得见，看得见。
Yeah, good evening, everyone. I'm very sorry, and maybe some problem. I didn't know what's the reason. So, I want to show you some cases. We treat the abducens paralysis use MVD surgery. So this is the first cases. You can see the female patient. She suffered the right ear, the abducens paralysis. You can see her right ear cannot abduct for 2 months, and the etiology is unknown. So for this case, we use the MR scan. You can see the larger is a blood vessel passing through the right CV ankle. Then we think this maybe is the opening vessel. So for this cases, we make the treatment plan to do the MVD surgery. So this is during the surgery, we found the ACA comprise the abducens nerve here in the RZ region and the obversion of the compress here. So for these cases, we use a sponge. We put some sponge between the artery and the abducens nerve. After this, we put some Teflon sponge between the sponge and the vessel. And this procedure is very easy and this is very useful to protect the nerve. And this is the same to do the MVD surgery for the hemifacial spasm. So you can see 4 months after surgery, the symptom of the patient's right abducens nerve paralysis was significantly improved. And the diplopia improved significantly. So the patient felt very well. Now this is the male patient. You can see his right ear cannot abduct for 1 month. And the etiology is unknown. So for this case, we also do the MR scan. From the MR, we can see the bilateral, the VA shifted to the right side. And some large blood vessel passes through the right CV angle here. So we think this artery may be the optic vessel. So for this patient, we also use the MVD procedure. So you can see 3 months after surgery, you can see the symptom disappeared. And the diplopia improved significantly. And the patient felt very well. Now this is also another young male patient. Now his right ear cannot abduct for 5 months, and the etiology is unknown. So we also use the MR scan. We can find the large the blood vessel passing through the CV angle here. And we think this may be the optic vessel. So we also do the MVD procedure for this patient. So you can see during the operation, we find the ACA compress the abducens nerve here in the RZ region. And we dissect and move the ACA from the abducens nerve, and then we put some tablet here between the nerve and the vessel. So 2 months after surgery, you can see the symptom of the patient significantly improved. And the diplopia also improved significantly. And the patient felt very well. Let's see another young patient. His right ear cannot abduct for 2 years, and it already is unknown. So for this cases, arm scan show the large blood vessel passing through the right CV ankle here, and we think this vessel may be the opening surgery. So we do the same MVD surgery for this patient. So during the operation, we find the ACA here compress the abducens nerve in the eyes region here. So we dissect and move this artery from the nerve and put some Teflon between the artery and the nerve. So you can see 4 months after surgery. You can see the center of the right abducens nerve was improved significantly. And the diplopia improved significantly, and the patient felt very well. So, in conclusion, the vascular compression may be the cause of the primary oculomotor nerve paralysis and abducens nerve paralysis. And the MVD is an effective treatment for primary ocular nerve paralysis and abducens nerve paralysis. The PC and IC are the main responsible vessel for primary ocular nerve paralysis. And the ACA is the main responsible vessel for abducens nerve paralysis. That's all. Thank you for your attention.
Thank you very much, Professor Li. It's a very good presentation. So any question and comments, please?
Yes.
This one, please.
Thank you, Professor Li, for your insightful and forward-thinking presentation. You create new field in cranial nerve surgery. I think in future we also to try to do surgery like this. But I have some questions. Could you clarify your inclusion criteria? Do you require imaging confirmed neurovascular conflict in all cases, or some decision you make in clinical manifestation of nerve paralysis?
In my opinion, till now, more than 50 patients was treated in our department. From these cases, we find before the operation, we should make the right diagnosis. First, we use medical treatment, and if there's no use, and with MR or the CT scan, you find nothing, no tumor, no aneurysm, no anything. So we use 3D top of the MR scan. You can find some vessel compressed nerve. So for these cases, you can try to use the MVD procedure to treat the patient. And in order we find more than 80% of our patients could get the better result. So maybe in the future you can try this procedure.
Thank you, Professor. And one question about pathogenesis of this process. In case of hemifacial spasm and trigeminal neuralgia, we have hyperactive dysfunction of nerve. Hyperactive, it always has some hyperaction. And in case of paralysis of abducens nerve, in your opinion, why is manifest like hypoactive process? We always have paralysis. We haven't any tics or spasms. It occurs with paralysis. In your opinion, what is the difference between two compression in case of hemifacial spasm and in case of abducens paralysis? Why in one case it has hyperactive process, in second hypoactive?
专家他问什么问题啊？啊，专家，哎， Okay, I get the question. Okay. I think the pressure is the same with MVD surgery to do the trigeminal nerve or the hemifacial spasm, but it's more difficult because it is very deep. You know, very deep of the places to do the section, and we should protect the frontal lobe and the temporal lobe, and it is very is a distance to expose and to do the surgery. So it's very more difficult. I think it's more difficult. But after expose the artery and the nerve, I think it is same. Is the same. So first you should shaft dissection around the nerve, and then you should move and the artery from the nerve, and you should get more large space to put some sponge first, and then you put some Teflon between the sponge and the nerve and the artery, and this is procedure is helpful to protect the nerve. And from our patient to do the MVD surgery for the trigeminal nerve and the facial nerve, I think this procedure is very useful to protect the adhesion after surgery.
Thank you, Professor. Thank you. Thank you again.
Yes, thank you.
For great talk.
Is there any further questions and comment, please?
So, Professor 钟教授，你好，OK. Professor Li, Professor Li, I have a question. Do you have cases without offending arteries or vessels during the operation you performed MVD? Because I have a case without offending vessel in the MRI scan, but the symptom is very clinical. It's very classic. So I want to I want to know if there's no we can't find offending artery in the MRI. Should we perform the operation? Do you have some experience? Thank you.
Yes. This is a good question. Yes, we we have many cases just like you said. Yes, during the operation you find nothing, no opening artery. So for this cases, we always use first. We should use a sharp dissection around the nerve. We should cut the adhesion, maybe the membrane. And then for this case, we will always use the combing surgery. The combing, the combing surgery. You combing surgery. And I think this is very safe. It's a procedure, very safe. And it's very useful to protect the symptom disappear. So we always, the first you check if you find nothing, you can use this technique.
OK. Thank you very much. 谢谢你，谢谢李教授啊。OK. Thank you.
Yes, Prof.Yuan Li. Do you have a question?
Professor Li, I have a small question to ask. How long time you and your team observe the same symptom before the surgery? And this is a small question. And another is, have you ever considered the facial nerve inflammation to do this MVD?
Okay. Thank you for your question. For the MVD surgery to treat the oculomotor nerve paralysis and abducens nerve, more than 2 years. more than 2 years.
Oh.
And more than 50 patients was treated in our department. And I think this procedure is safe. If you do the procedure for the abducens nerve, maybe this is the same to do the surgery MVD for the facial nerve spasm. And this is very safe. But the you know, the abducens nerve is more deep. His place is more deep. Yeah. So, but the the approach is the same. Approach is the same, just between the between the 7 and the 9. Yeah, you can. I don't think it's difficult. It's easy there.
My question is that you, how long time you observe this symptom, abduced nerve paralysis or an abundance nerve paralysis, the symptom, the paralyzed symptom, how long time you observe it and then to do this surgery?
Yes, it's a good question. So for our patient, first we should make the right diagnosis, and first we use medical treatment. You should use the medicine. You first use the medicine. More than 1 month. More than 1 month.
Have this more than 1 month. Oh, okay.
Yeah, more than 1 month. Yes. Thank you.
Have this. Oh, okay. I also want to ask a question. When we in the clinic, we often see some patients come here and bring his MRI scan to us, and we can see some patients suffer from. They also have the offending vessels. To compress the facial nerve. How do you consider this condition?
In my opinion, during the surgery, if you find some artery connected with the facial nerve, I always dissect and move all these artery from the nerve. So from the region 1 to region 5, we should check. So around the facial nerve, we should check every artery. If you find contact the facial nerve, you should decompression each artery.
Okay. Thank you.
Yeah, thank you.
Professor Jun?
Yeah, is there any further questions? You don't have any question, I would ask Professor Keto make a conclusion for us. Please, Professor Keto.
Okay, thank you so much. So we had the 3 great lectures from the 3 expertise. I think the 3 doctors had lots of experiences. I think then according to their philosophy and the techniques and maybe educational background or teachers, so they believe the method how to decompress of the artery from the nerve. But I think all successful the result is, I think that means is all technology is fine, I think. And another thing is, so maybe it's very first listen about some decompression from the nerve from by Dr. Li. It was very, very fresh for me, but I think maybe in the future, if there is some such case, we can wait 2-3 years, then maybe we can try, I think. Anyway, it was very nice webinar. Thank you so much.